Today I'm going to discuss an important issue in managing chronic kidney disease patients or dialysis patients, which is an inflammation, which is a universal amplifier. First of all, I'd like to thank Professor Sheashaa who gave me this opportunity to speak about an important issue. To start with introduction, this is the cost of indecision disease in the United States. As you see, the cost is increasing through years from this value, billions of dollars, to this value, so the enormous amount exerted for the management of these patients. Although the trend is toward the improvement in mortality, still the death in end-stage kidney disease is very high. The most stable is renal transplantation. There is survival advantage for transplant patients in comparison to hemodialysis or peritoneal dialysis patients. This is a gloomy and depressive slide because survival in dialysis is lower than many cancers, as you see. The 5-year survival for this patient is black colored. It's actually black because mortality survival is lower in dialysis patient in comparison to prostate, thyroid, breast cancer, etc. One of the reasons why this patient died, the MIA. What's meant by MIA triad? It's abbreviation for malnutrition, inflammation, and atherosclerosis. So inflammation is one of the most important factors causing death in this sector of patients. Malnutrition can lead to inflammation. Inflammation can lead to malnutrition. Both can lead to atherosclerosis and cardiovascular death. What are the factors that induce inflammation in this type of patients? We have factors related to chronic kidney disease and additional factors related to dialysis. So if you look to the chronic kidney disease patients, you'll find a lot of uremic toxin, and one of the important uremic toxin is picresol sulfate and inoxal sulfate. Reduces clearance of pro-inflammatory markers because of chronic kidney disease, increase in cytokines, acute and chronic infections, impaired intestinal barriers, oxidative stress, free light chains, serum amyloid A, volume overload is very important. We shouldn't look at volume overload as just volume overload because it impairs the intestine barrier for toxins and infections. Autonomic nervous system dysfunction, mineral and bone disorders, edema, hyperhemostynemias, advanced glycation in the products, comorbidities, and increase in diabetes, COPD, heart failure, etc. So all these are factors related or common in patients with chronic kidney disease. Additionally, for patients treated with dialysis, if we can find bioincompatible elements in the extracorporeal circuit, like membranes, blood lines, vascular access infections, dialysate bargenic contamination. Here we should avoid acetate because acetate is linked to inflammation, exit site infection, peritonitis, high glucose in peritoneal dialysis. So a lot of factors are common in patients with chronic kidney disease and on dialysis that can lead to inflammation. And again, the correlations of inflammation or hemodialysis and immunity, this is a complex interrelations because the cells are affected and the dialysis patients in a state of under immunity or immune suppressed, and there is also increased inflammation, as you see here in stimulation of complement and inflammation. One of the most important amplification is mortality. So inflammation increases mortality. And this is the most important solid outcome criteria when we address any criteria or outcome. Look here, if malnutrition inflammation score increases, the log hazards for mortality increases. This the confidence interval, and this is the log hazards of mortality. So there is a correlation between increasing inflammation and malnutrition and mortality. Another study from Turkey, which addresses inflammation, infections, and comorbidity in patients on long-term dialysis. And here they used erythrocyte sedimentation rate above 50 as a marker of inflammation, although we don't like SR because there are a lot of markers to be used and more important than the use of SR. But look here, if SR above 50, survival is reduced significantly. Another study, and this is from Japan, the impact of metabolic disturbance and malnutrition, inflammation on 6-year mortality in Japanese patients undergoing hemodialysis. Here, they correlated inflammatory markers with all-cause mortality or cardiovascular mortality. So the higher the TNF alpha and or high sensitive C-reactive protein, the higher the all-cause mortality, and the area under curve is very broad. So long as it is above this oblique line, this is significant variables, and the p-value here is highly significant. Again, the higher the inflammatory markers, TNF alpha and high sensitive C-reactive protein, the higher the cardiovascular mortality. So this study showed that the higher the inflammatory markers, the higher the mortality and the higher the cardiovascular mortality. Another inflammatory markers, interleukin-6, is very important and correlated with many comorbidities and complications and outcomes. And this is the hemodialysis and this increasing level of interleukin-6 associated with higher mortality, and increasing interleukin-6 receptor also associated with mortality. So inflammation is a risk for mortality. Inflammation is correlated with mortality. Another important is the comorbidity, frailty. Here, if you look, for inflammation induces frailty and also leading to sarcopenias and affecting the poorer outcome. What's meant by GNR index? It is geriatric nutrition risk index, and this is the equation for this index. Album multiplied by factor, weight divided by ideal body weight multiplied by another factor. So here, if albumin is negative or positive phase reactant, by another way, if there is inflammation, albumin increases or decreases? Albumin decreases, because albumin is negative phase reactant. So I won't just stress on this point, because if the index is low, this means that inflammation is there or malnutrition is there, and both of them are associated with mortality. So if you look here, if the index below 96, you find that TNF alpha, high sensitive reactive protein, is associated with increasing hazard risk for all-cause mortality. And this inflammatory markers are attenuated by the index. If it's above 96, it lost its significance. P-value is insignificant here and there. So it is an important issue to be addressed when we evaluate the patients in this domain. Regarding the inflammation explanation, why the mortality in dialysis is more common in Caucasian in comparison to African American, this is dialysis paradox or racial paradox, because the response of Caucasian to inflammation is completely different from the African American. Find here if you look here, this is the Caucasian with high C-reactive protein, mortality is high, and this is a control, and then in the intermediate, and this is a control. So you can you look at the color codes, and you find that there is some discrimination regarding the race and response to C-reactive protein. C-reactive protein divided by albumin fluctuation. It's important they divide the patients into 4 categories: group 1, 2, 3, 4. So here I want to stress on the fluctuation in serum. High C-reactive protein is associated with poor outcome. And if we look at C-reactive protein, is it only a marker for inflammation, or can be indulged as a causal factor for the comorbidity? There are accumulating literatures showing that it may be a marker and cause of problems. Here another factors, inflammatory, if you find is stable and decrease, this percent survival. If inflammatory marker is stable and low and decrease, the survival is the best, but stable high, the survival is poor. So we should look at the serial changes of the inflammatory marker. So here I addressed inflammation and mortality. So inflammation is a universal amplifier for increasing mortality in CKD and dialysis patients. Another sector, progression of diabetic kidney disease. Is there a link between inflammation and the progression of diabetic nephropathy or diabetic kidney disease? If you look here, this is TNF receptor 1 and this is TNF receptor 2 by picogram per ml. The higher the TNF receptor, this means the higher TNF, tumor necrosis factor, the higher the albumin creatine ratio. And here, this is the, if you look here to the by univariate or multivariate, you find increasing hazards for the inverse and multivariate Cox, adjusted Cox proportional hazards model for the risk of end-stage kidney disease associated with TNF receptor 1 and 2. This means the higher the TNF receptor, the higher either 1 or 2, the higher the other risk for end-stage kidney disease in univariate and multivariate analysis. Regarding the endothelial dysfunction and inflammation that predict progression of diabetic nephropathy in African American with type 1, as shown in this study, another study showed that hyperuricemia is associated with progression of chronic kidney disease, and one of the explanations why hyperuricemia leads to progression of chronic kidney disease is increasing inflammation, as you see here. So the increasing inflammation is one of the reasons why hyperuricemia leads to progression of chronic kidney disease. Metabolic acidosis can lead to progression of chronic kidney disease, and we usually neglect the treating the metabolic acidosis in early phases of chronic kidney disease. We should look at serum bicarb, and the KDIGO guidelines recommends serum bicarb to be above 22 millimole per liter in the patients on chronic kidney disease to avoid the progression. Why metabolic acidosis is associated with progression of chronic kidney disease is through increasing inflammation, endothelin, complement, etc. Another study showed that the tumor necrosis factor alpha polymorphism in patients with end-stage kidney disease associated with this progression. Individuals with homozygous TNF alpha polymorphism appear to have a significant association with chronic failure and end-stage kidney disease, and thus this may be a predictor for development of disease. These patients all demonstrated elevated serum TNF alpha, which may be a contributory factors. A very important concept is using multi-maker approach. Not only one parameter, but we should look at different parameters like the NET, BNP, and C-reactive protein. Every item of these three parameters is scored into first, second, third tertile. So the higher the tertile of C-reactive protein, as you see, this is the correlation with all-cause mortality, free survival. So if here the blue color in C-reactive protein reveal the lower tertile, so C-reactive protein is low, survival is higher, is better. If C-reactive protein is high, the survival is reduced. Also, inflammation is associated with coronary artery stenosis, and if we look at the puzzle, risk factor puzzle for coronary heart disease, we find a lot of factors, traditional factors like smoking, dyslipidemia, etc., endothelial dysfunction factors, calcification, and one of important corner of puzzles that leads to coronary heart disease in patients with CKD and dialysis is inflammatory biomarkers. So this is another study showing the cardiorenal syndrome is associated with inflammation, and here the higher C-reactive protein, the higher the left ventricular mass index. And this is the distressing symptom of uremia, which is pruritus, is linked to inflammation. Pruritus is very common in adult patients on dialysis. It's more than 18%, so 1/5 of patients suffer from this distressing symptoms. And one of the causes of the pruritus or chronic kidney disease-associated pruritus is inflammation in cytokines. Clothes to protect against indoxyl sulfate. As I mentioned before, indoxyl sulfate is an important uremic toxin. And here, this is a correlation between indoxyl sulfate and clothes. So clothes is a hormone secreted by the kidney. It is present as full length on the receptor on the renal tubules and secreted by secretase as a secretory part, secretory hormone. So if we look at the level is inversely correlated to indoxyl sulfate in dialysis patients, and it's correlated with a high left ventricular mass index. So left ventricular mass index increase, the heart become heavier and the muscle become thicker if inflammation is there, if the clothes decreases and indoxyl sulfate increases. And this is the experiment in rats. They induce the uremic model by injecting the rat with intraperitoneally with indoxyl sulfate that leads to left ventricular hypertrophy, and that was ameliorated in this experiment by using closo. Important clinical parameters is blood color. In this study, they measure the blood color by using calorimetry, and very important, it is correlated with the C-reactive protein and white cell counts, and positive correlated with oxygen saturation. This is very important to look at the blood concentration. So the darker the blood is, you can expect the more hypoxemia and more inflammatory markers in this blood. Cell-free DNA from cell necrosis increases with inflammation, and circulating cell-free DNA levels in hemodialysis patients and its association with inflammation and metabolism and recombinant human acidosis is addressed in this letter to the editor. Another issue which is considered as a predictor of cardiovascular event in incident dialysis patient is neutrophil divided by lymphocyte percentage. So if you find the quartile, this is the cardiovascular event-free survival. So if the quartile of neutrophil divided by lymphocyte is 1, it means the level is between 1.1 to 2.7, survival the best. But if the quartile is 4, it means the ratio is 4.66, the survival is markedly reduced. So neutrophil divided by lymphocyte is considered an important parameter. Another parameter of inflammation in dialysis patients, which is delta HE. What's meant by delta HE? We have reticulocyte, which is considered as a precursor for erythrocytes. So if the iron is available, the hemoglobin inside the reticulocyte is higher than erythrocyte. Why? Because of survival of erythrocytes. But if the iron is not available, and iron is not available in dialysis patients whenever there is high inflammation, because inflammation stimulates the release of hepcidin from the liver, which makes iron unavailable for the reticulocyte and erythrocyte. So delta hemoglobin or hemoglobin inside the reticulocyte decreases if there is inflammation, hepcidin is there. And you can see this is the correlations of delta hemoglobin with different parameter address inflammation. Here was albumin, high sensitivity reactive protein, interleukin 6, and ferritin. If you look here, the albumin is lowered, delta hemoglobin is decreased. Here, delta hemoglobin is decreased if the delta hemoglobin is decreased if SR increases, if C-reactive protein increases, and the same with interleukin 6 and ferritin. Serum hepcidin level, very important factors, as I mentioned before, secreted by liver, lead to resistance of availability of iron, and this is the correlation of C-reactive protein with hepcidin. You find the increase with high inflammation. So what I mentioned up to this moment, inflammation is bad, associated with mortality, comorbidities, progression of chronic kidney disease. So it is universally amplifying all these events. And I mentioned in a sentence that it's not only if you find the inflammatory marker is not just only a marker of inflammation, but maybe indulgent in causation. So this is an important issue. So how to manage and handle inflammation? We have two routes. The first is eliminate and remove. So elimination of factors triggering inflammation and the removal of inflammatory mediators. So how to eliminate of factor triggering inflammation? By using biocompatible membranes, biocompatible bloodlines, acetate-free dialysis, bicarb dialysis, ultra pure, so should improve the water treatment, high quality water treatment systems. So these the biocompatible ways. How to remove the inflammatory mediators? By using high volume convection. In dialysis we have diffusion and convection. Diffusion depends on molecular weights, and the convection is very important because it drag many mediators. Diffusion plus convection, sorbent cartilage absorption, absorbing membranes, high flux membranes. So this is the way how to remove model molecules and etc. So we should improve the surface of the dialysis to get rid of inflammation. Again, if these are the factors that increase inflammation, so we should address them and treat them radically. Left-ventricular hypertrophy, dialysis, catheter contamination, bioincompatible membrane, uremic toxin, fluid overload, and I mentioned before, the fluid overload leads to derangement of the intestinal barriers. So these factors should be addressed and treated. The dietary salt restriction important and decreases inflammation. Maintaining residual renal function, because the lower if you lost residual function, inflammation increases. The using of friendly drugs that target inflammation, like ACE inhibitor, statin, aspirin when indicated. Arteriovenous fistula rather than catheter. Optimum use of tonics and vitamins and iron. One of important parameters to be addressed is encouraging patient dialysis on CKD to exercise, because if the patient stays immobile, this increases inflammation, as you see. Using dietary fiber, the effect of fermentable dietary fiber supplementation of oxidative and inflammatory states in hemodialysis patients is raised in study. It is multiple, so it's 3 arms. Arm given 10 gram fibers per day, and arm 20, and they control here, and they address all inflammatory markers. All inflammatory marker decreases whenever the fibers are supplied. And the effect of dietary fiber, as you see, it suppress dietary acid load, increase fermentation, the proteolytic fermentation in phenol, it suppress insulin, so it increases insulin sensitivity and decreases inflammatory and oxidative stress. So dietary fibers and the protein nutrition therapy in chronic kidney disease are an important step in management of inflammation. Using flaxseed, as you see here, improves lipid abnormalities and it can lead to decrease of inflammation. Use of ACE or ARBs are friends for inflammation. Statin here, this is the level of C-reactive protein. For patients treated with statin, C-reactive protein decreases from this level to that level at the end of the study, but for the control it increases, or static again here decreases, and here static for interleukin 6. So inflammatory biomarkers decreases with the use of statin. This is another study showing the beneficial in this systematic review and randomized control trial. The author showed that in dialysis patients, statins affect the chronic inflammation status favorably, as reflected by reduction in serum C-reactive protein and high sensitive C-reactive protein levels, but don't improve the nutrition status as reflected by serum albumin. If I say this statin is beneficial, I'm not defending the use of statins for all hemodialysis patients, because we know the guidelines that the use of statin is debatable, and it is, yes, recommended in chronic kidney disease, but is not recommended for dialysis patients except if there is indication from the cardiology point of view. If you document L-carnitine deficiency, because L-carnitine deficiency is linked to inflammation, treat the patient with L-carnitine. Avoid using catheters, because catheters increase inflammation. The vitamin E coated membrane may be valuable, especially if there is inflammatory biomarkers. And this is an important issue regarding the induxyl sulfate. This is one of the modalities of management, is to use absorbing capacity of AST 120. It's given oral to decrease the induxyl sulfate toxins, because they are very important in the regarding the last sector in my presentation, which is hemodiafiltration, on-line hemodiafiltration. The effect of hemodiafiltration with endogenous reinfusion on overt idiopathic chronic inflammation. They prove the inflammation is idiopathic by excluding all causes apparent for inflammation. Here, this is the concept. The convection is here, and the diffusion is in this part, and there is adsorbent cartilage, so this improves the inflammatory marker into decreasing of the C-reactive protein and decreasing all inflammation. If we address the issue of on-line hemodiafiltration, we have 4 types of hemodiafiltration: post-dilution, pre-dilution, mid-dilutions, and mixed dilution. For post-dilution, ultrafiltrate followed by infusion of replacement fluid. Pre-dilution, infusion, replacement fluid followed by ultrafiltration. Mid-dilution, infusion of replacement fluid at the midpoint of ultrafiltration. Post-dilution followed by pre-dilution, and a mixed infusion of replacement fluid before and after ultrafiltration. If we address all these issues, we'll find that the most important and the best modality to be used for managing this patient to get rid of inflammation and to cut short this cycle is the post-dilution hemodiafiltration. And not only the post-dilution, but the high fluid, high volume on-line post-dilution hemodiafiltration. This means more than 20 liters. And this study showed, it is the Sheashaa study group, showing that the high efficiency post-dilution on-line hemodiafiltration reduces all-cause mortality in hemodialysis patients, and this is a significant difference, as a p-value is significant. Survival is better for on-line hemodiafiltration, and it decreases the hazard risk to 0.7. On-line hemodiafiltration reduces systemic inflammation compared to low flux hemodialysis. This is from Canada, and this is another study. Crossover study included a few number of patients, 40 patients, 20 patients treated with bicarb hemodialysis, and the others treated with hemodiafiltration on-line treatment B for 6 months, and then crossover is done. So the patient treated in phase A with bicarb dialysis treated on the phase B with hemodiafiltration, and the hemodiafiltration phase A treated with bicarb dialysis in phase 2 until the end of the study. And in this study they showed that if you look here, the hepcidin is reduced, and hepcidin is removed by on-line hemodiafiltration, and this explains why the resistance for EPO, for estrogen stimulating agent, decreases with the use of on-line hemodiafiltration. In hemodiafiltration, more favorable than hemodialysis for treating renal anemia, and this is the explanation or the concept. If we use high volume on-line hemodiafiltration, this will increase clearance of small and middle molecules, decrease plasma hepcidin, that is important in the causation of resistance to anemia management because it makes iron unavailable. It decreases inflammation, on-line hemodiafiltration decreases inflammation, decreases oxidative stress, and if all these are improved, ACE resistance will improve too, and this may be linked with improved survival. So we still need a lot of studies in this issue, but this study, although it included few number of patients, but shows that high volume on-line hemodiafiltration is superior to bicarb dialysis. Another study from Saudi Arabia, published in Saudi Journal of Kidney Disease, it is the effect of on-line hemodiafiltration improving the cardiovascular function parameters in children on renal dialysis. Another study showing this is Turkish on-line hemodiafiltration study showed that there is no significant difference, and the explanation is between the high flux hemodialysis and on-line hemodiafiltration may be because of the not using high volume on-line hemodiafiltration. So, and this is if we respect the high volume, the results improves. Here the optimization of the convection volume on-line post-dilution hemodiafiltration, the practical and the technical issues. Before we are going to recommend on-line, we cannot recommend on-line hemodiafiltration for all patients because we should have all the facilities that can help us in delivering on-line hemodiafiltration. We should ensure adequate dialysis time. We should ensure adequate blood flow, selecting the proper vascular access, monitoring accessory circulation, consider discrepancy between set and all values, optimize filtration fraction. By all these means, it shows hemodiafilter with high hydraulic permeability, avoid single needle circuit, perform regular technical and teaching and feedback on the nursing staff, reevaluate on frequent basis. So we should improve the service altogether to deliver this parameter. Here I want to just end my presentation by saying it's better to look ahead and prepare than to look back and regret. So we should improve the service altogether. It's not a matter, we shouldn't focus on high flux only, hemodiafiltration only. We should focus on all the service. So we should work together with different personnel, doctors, nurses, physicians, nutritionists, the use of the best machine, best dialyzers, best dialysate, best modality. All these work together in a symphony toward the best outcome for our patient. Thank you for attention.